Welcome to the 370th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from Daejeon, South Korea. Today, I welcome long COVID activists Teresa Tyndall Akintunwa and Lisa Mccorkle. Just a reminder, you can usually catch COVID calls live on weekdays at 6 p.m. Eastern Time. Just go to the COVID calls YouTube channel to watch. You can hear COVID calls anytime recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID calls via Twitter using the handle @US of Disaster or @COVID calls. Please help spread the word and send suggestions for future guests and future topics. As always, please feel free to suggest yourself as a future guest. We're getting great suggestions for future programs, and right now we're booking COVID calls all the way out into the end of the year. So if you have an idea for a COVID calls episode, please get in touch. As of today, November 2nd, 2021, there are 5,008,694 deaths from COVID-19 globally. That's according to the Johns Hopkins University Coronavirus Resource Center. I've been reading an obituary or a story of advocacy for those impacted by the pandemic, and I'd like to continue that now. The headline is Britain's longest known coronavirus patient dies aged 49. This was written by Miranda Bryant and appeared 19th of June, 2021 in The Guardian. A man believed to be Britain's longest known coronavirus patient has died after deciding to withdraw from treatment. Jason Kelk, age 49, was admitted to St. James University Hospital in Leeds after contracting COVID-19 in March 2020. He died in June, surrounded by his family after being transferred to a hospice. His wife, Sue Kelk, shared news of his death on that Friday in June, so this comes from June of this year, and said that Kelk, who was a primary school IT worker, passed away peacefully. It's with a very heavy heart that I have to share the sad news that Jason passed away peacefully at St. Gemma's at 12:40 p.m., she wrote on Facebook. Paying tribute to her husband of more than 20 years and soulmate, she said his death was so peaceful. It was definitely important for him to do it on his terms, but he's leaving an awful lot of people absolutely bereft, she told the Yorkshire Evening Post. People might not think he's been brave, but my God, he has been brave. I really think he has. And I just think that this is the bravest thing that you could ever do, to actually say, I don't want to live like this anymore. Last month, she told Sky News that she feared her husband had given up after his condition worsened and he started experiencing fainting attacks. Before then, she had been preparing for him to return home, launching a crowdfunding appeal to help pay for it to be converted for him. Kelk, who had type 2 diabetes and asthma, was transferred to intensive care in April of last year and remained on the same ward until he went to hospice. The virus damaged his lungs and kidneys, and he developed severe stomach problems, and that meant he had to be fed intravenously. Earlier this year, 2021, he appeared to be recovering, starting to walk and coming off of a ventilator and the 24-hour kidney filter. Before his condition worsened, Kelk said her husband was drinking tea and soup and sending text messages. He told the Yorkshire Evening Post in March that he hoped to return home to sit on our sofa and eat takeaway fish and chips with Sue while we watch the telly, something normal like that. He said, my family is what kept me fighting. It would have been a very different year without them here. When his condition worsened in May, he had to be put back on a ventilator and then developed 2 infections. Jason Kelk died surrounded by his wife, mother, father, and sister, and leaves behind 5 stepchildren and 8 grandchildren, 2 of whom he had never met because they were born in the past year. Okay, let's turn to the conversation for today. Let me introduce my guest to you. Teresa Tyndall Akintunwa is an education specialist, patient advocacy blogger, and founder of the Black COVID-19 Survivors Support Group, an online community aimed at helping African Americans overcome the misinformation, exclusion, and trauma of having COVID. Teresa herself contracted COVID-19 early in the pandemic back in February of 2020 and has been contending with physical and cognitive impact ever since. My second guest is Lisa Mccorkle. Lisa is co-founder and patient researcher with Patient-Led Research Collaborative, a group of people with long COVID who conducted the first and most comprehensive research on long COVID. As a result of her research with the Patient-Led Research Collaborative, she has testified to Congress, presented to the White House COVID-19 Health Equity Task Force, and been featured in The Atlantic and The Wall Street Journal. In her day job, she's a policy analyst at the California Department of Social Services. She received a master's in public policy from the University of California at Berkeley and a Bachelor of Arts in political science from the University of California, Los Angeles. Terry Akintunwa and Lisa Mccorkle, thank you so much for joining me on COVID Calls today.
Thank you for having me.
Thank you for having us.
I'd like to start the way I generally do, finding out where you're calling from and what the pandemic situation is looking like there at the moment. Terry, can I start with you on that?
Sure. I'm in Atlanta, Georgia. And as you may know, we are, I guess, formerly a red state. And what that means is that sometimes the actual condition of the pandemic, can be misconstrued or interpreted through political eyes versus through the reality of what's actually happening. We are having some increase in the number of COVID cases that are coming up, but I can tell you they're definitely not as severe as cases that I saw coming in up until probably about February of this year.
And what's happening in terms of vaccination there in Georgia? Any sense of the rates and the uptake?
Sure. I think we've had pretty healthy vaccination rates. People generally are understanding the need for it. The fear of, I guess the myths and the conspiracy of, government sanctioned vaccines does exist in some circles. But overall, most people are getting vaccinated, but we still have, those holdouts. We still have people who are extremely distrustful of the vaccine. And I would say definitely that the recent mandates for government workers to get vaccinated has not helped. It's something that kind of has further fed into the distrust and conspiracy theories about the vaccine. And believe it or not, even socially, there's been some implications. I've seen quite a bit of people disassociating from friends and peers who have chosen to get vaccinated. That's something we wouldn't really expect, though, right? You kind of want your circle that you're going to be exposed to have the vaccination. And unfortunately, here in Georgia, I'm actually seeing the opposite.
Lisa, let me bring you in on that same question. Thank you, Terry.
Yeah, I'm coming to you from Oakland, California, so the Bay Area. And here we've seen a pretty drastic decrease in cases over the last couple months. The most recent surge is going down, which is great. And we have, in terms of vaccination rates, we have nearly 90% of those eligible ages 12 and up have at least one dose of a vaccine. So just yesterday, Alameda County, the county that Oakland is part of, rolled back some of the masking requirements, but they're moving fairly slowly in terms of rolling back any of those restrictions, which I think is a good move. In June, it just kind of was a free for all. It very quickly, all of our mask mandates were removed, and I think that really contributed to the most recent surge. So I think the slower we roll those back, the better.
Lisa, let me stay with you and ask you if you wouldn't mind sharing a memory of this pandemic time. And I realize I usually call this the impossible task, because finding one thing that you think sort of stands in for COVID is pretty hard. But is there some moment in time in this pandemic that really sticks with you?
Yeah, I mean, I wonder if this would be similar for most people. It was just at the beginning, and especially for folks that had long COVID. I'm sure it's when they initially contracted COVID. But yeah, for me, I think the biggest memory that stands out is I got sick on March 14th, 2020, right as the world was shutting down. And that whole experience is the reason why I'm here with you today. After a couple months, I realized I wasn't getting any better. I kind of miraculously found a support group online called Body Politic, where thousands of other people were also going through the same thing I was. And at that point, no one was talking about long COVID or these longer term symptoms that many people were having. And then a subset of us within that support group formed a research group to try to just collect all the data that was being shared and try to help figure out what was going on with us and why we weren't recovering. And that research group really has been my saving grace in so many ways this last year. I've met some of my best, closest friends through that, have had incredible support while dealing with a disability. And it's also just provided so many opportunities for advocacy, not only for people with long COVID, but also for people with other post-viral illnesses and other chronic illnesses that are related to long COVID.
Terry, let me bring you in. Thank you, Lisa, for sharing that. Same question to you, if there's a moment in this pandemic that really stands out for you.
Sure. I think the moment that stood out the most was when I was able to have my first in-person visit with my doctor last year after the shutdowns. Most people were only being able to be seen through televisits. And I recall having a very severe headache for months and trying to tell people, about this headache and, hearing the responses that, every single day you have a headache, and I'm like, for real, no exaggeration. I've had this headache every single day that was becoming quite overwhelming and distressing. But being able to get to the doctor and explain that to her and have her actually take it seriously at that point really was impactful for me. It's a really terrifying experience to have had COVID, especially earlier on, right? Where there's no information, not enough patients who have recovered to really be able to tell their story. And so being disconnected from your healthcare provider, during that time really leaves you hopeless. And I struggled a lot. I struggled to get up every day. But to have her hear me and understand that, these symptoms are real. This is not a result of stress. This is not a result of a shutdown. This is not anxiety, that this is a real physical ailment that's happening to me. It really was the game changer for me because I felt like I had an ally. And that person didn't have to have had COVID herself for her to have empowered me, but she did by believing me and doing what was in her power, to do for me.
Thanks for sharing that. I think we'll probably want to come back to that, the way that people, when they long COVID sufferers tell their symptoms to somebody in medicine, how they're reacted to, what their reception is important. There's something you said there I wanted to just pick back up on real quickly, which is that you didn't feel that you could get that kind of interaction in telehealth, or you just didn't try. You really wanted to wait until you could go in and physically be with the doctor to explain your situation. I know it's a personal question. We don't have to touch on it if you want to, but it was an interesting detail, I thought.
Sure. Well, I would say that I didn't try to a degree. The appointments were so far out and books, everybody was seeing a doctor. So it was difficult. But also I felt like, this is a physical ailment and I really need to be seen in person. I need my vitals checked. This is not, a moment for talk therapy. I need to be seen in person and assessed. So yes, to a degree, I could have gone in earlier, through the health appointments that were available. But for my situation and just as extreme as my headaches were, I really felt the need to be present.
That makes a lot of sense to me. Thanks for clarifying that. Terry, let me stay with you. I think it's sort of a basic question here that you probably get asked all the time, but how do you define what long COVID is?
Good question. The way I define long COVID is basically, any person who's really still living with the fallout or the side effects of the virus, dealing with symptoms that were not present prior to having contracted COVID. So, those lingering things that for sure only showed up, post virus, that you're still dealing with. That's what long COVID is, to me.
Lisa, let me bring you in if you want to add anything to that. And I'm curious also in terms of the big questions that are out there for researchers. I guess it's probably an unlimited number of questions right now, but also your sense of how you define long COVID and what the research frontier looks like.
Yeah, it's one of the biggest questions that's asked is how do you define long COVID? And the World Health Organization has their own clinical definition. CDC has their own definition. But generally, it's basically what Terry was saying, which is, it's having these prolonged symptoms, and it can even come from an initially asymptomatic infection. You don't have to have symptoms in the first couple of weeks of illness. But generally, whatever kind of the research realm and healthcare is leaning towards is this definition of experiencing symptoms from a confirmed or suspected case of COVID for at least 2 to 3 months is kind of what the agreement is. And many times it is an illness that is fluctuating. So symptoms often come and go. There are relapses. There are different things that trigger symptoms to come back or make them worse. The top 3 symptoms that we see in our research as Patient-Led Research Collaborative is post-exertional malaise. That is where symptoms become worse after some kind of exertion. That can be physical exertion, mental, emotional, any kind. So post-exertional malaise is one of the top symptoms. Fatigue and cognitive dysfunction. Those are really the top 3 symptoms that we see. But it is really an illness that impacts every single system in the body. We've documented over 200 symptoms that people with long COVID experience. And in terms of some of the research questions that people are looking at, the NIH is just launching the Recover Initiative, which is their big study on long COVID. And some of the questions they're looking at is what symptoms are those kind of like hallmark symptoms of long COVID? How do those symptoms change over time? Those are questions that we've answered within our surveys. But then on top of that, what are risk factors for having more severe symptoms? What are the underlying biological causes of long COVID? What are the overlaps with other post-viral illnesses like ME/CFS, like dysautonomia? We're seeing a lot of commonalities between those illnesses. And I think that's what the long COVID community is really hoping for the NIH Recover Initiative and all these other research initiatives to look at is, we're really not starting from scratch here. Long COVID is not a new illness. It just is new in the sense that this part of COVID is new. But post-viral illnesses have been around for decades, and there is research on that. So let's build on that research. Let's make sure that this research benefits people who have been sick for decades from other viruses. And then the other thing, NIH Recover Initiative is not touching treatments right now, but there is some researchers that are looking at what kind of treatments might be effective for people with long COVID.
I didn't know much about that research trajectory of post-viral illnesses in the past. And is that something? I mean, how would you describe the attention that's been paid to that? Is it a well-funded area that just has been below the radar, or it's been something I haven't paid much attention to, or is this a lightly funded area that we're now rediscovering?
It's very lightly funded. It actually, given especially the disease burden and severity of these illnesses, it is one of the lowest funded areas of research that NIH funds, that are government funds, and even worldwide. And I mean, that's why we have this crisis right now, is because this area of research has not been funded. And, there is some, and we don't want to ignore the work that has been done, but we could have been so much farther along if this had been paid attention to before.
Terry, let me bring you back in on this. You're the founder of the Black COVID-19 Survivors Support Group. Talk a little bit about that, if you would, and specifically in terms of the research on people of color who've had long COVID. What are the research frontiers there? Is it somehow different from the other research that's ongoing? What particular kinds of work is your community interested in fostering?
Okay, thank you. Well, the Black COVID, Black COVID-19 Survivors is an online community. Its initial purpose was to provide support, not just to the actual survivors, but to the families of the survivors as well, and to family of those who, lost their battle with COVID. I was seeing a huge need for people to just really be able to gather, being separate as we were last year and everybody in isolation. Just being able to have that mental and emotional gathering was part of a necessary process to our healing. Being able to collaborate with others, understand what other people are going through who are similar to you, and frankly, being able to freely express what the fears were concerning the COVID, as well as reaching out to the resources that were being made available. And so, sorry, but
we always have co-hosts and other guests involved, and it's fine. It's very welcome.
Right. But my goal, first of all, is to help my audience to be properly educated about COVID, to dispel a lot of the community myths and rumors, right? And to encourage them to really seek reliable sources, credible sources of information. So that has been my primary goal. And then secondly is to provide strategies for my members to advocate for themselves. Without COVID, navigating the healthcare system can be very difficult, especially if you are a woman and especially if you are Black. And so with those two things combined, in a pandemic, something that most people have not encountered before, people need ways to speak up for themselves. And not just within the healthcare system, but even, when it comes to their needs on a social and economic domain, they need ways in order to approach, and solve their problems. So patient advocacy has been hugely on my heart. Is something I fell into. It's not something I have a background in. I'm an educator and trainer by trade. but really helping others to see, what paths can I take? What are the questions I need to ask? What is the follow-up that I should consider after seeing the doctor? When is a second opinion, warranted? Especially during a phase of time in which most of the doctors don't know much more than we do. And so just helping my members to not feel totally lost, and clueless and isolated has been my goal. As far as the research, I can say this. I think that people have made an effort to reach out to the Black community and other underserved, segments. But I think that in the process, it's been a very one-directional effort, meaning like I'm approached all the time, about, providing surveys, providing survey participants, getting feedback. And it's always kind of a gimme type situation where, organizations, universities, individual researchers, and so forth are all just trying to get information, and they just want the patients to just, somehow just splurge all of, their knowledge and experience without, creating any type of rapport or, when I say report, I don't mean individual report, but more of, how is this going to benefit them or their community in the long run if I do participate, right? What is the benefit to being a part of patient-led research? How do I, after I've given, my time to respond to questionnaires and interviews, making an effort to make sure that that information can be understood by the patients and know what its implications are. I don't think that's been done enough. And so part of my role is to kind of run relay in a way, to help educate my audience about the importance of participation, but also, share what information has come out as a result. I hope that answered your question.
Oh, there's so much in what you've just described, Terry. I think it's really important. There's one part of it I want to pick up on is the trust issue. And we look at infection rates of COVID in the United States. It has reached into the elder population, African-American population, people who are cut off in one way or another from the mainstream of the health system. And so I wonder, you're part of what you're describing with your group is an attempt to repair some trust or give people tools, I guess, to go and seek the help they need if they've already had. I wonder, I know you probably can't, maybe it's hard to generalize, but I wonder if you could characterize that a little bit. When your members of your group then have to go back into the health system to get help and describe something which is hard to describe, what kind of tools do they need? How do you help them sort of regain the trust to go back and get the help they need?
Right. So establishing trust, obviously can be very difficult. I think one thing that has been helpful, first of all, is explaining, how anonymity works in the healthcare system and just in research in general. One huge fear is that, if I return to my doctor, if I go to, one of these clinics that have, pop-up COVID clinic or that's been provided, and, they're going to somehow track me, and somehow that's going to follow me, to some type of disastrous end. We don't, know what exactly the end is that people anticipate, but, they really do fear being further segregated. And so helping them to understand just even how does research work, right? Why it's how you're put into a segment and group, but you're not identified. This type of education, I know it's a bit extreme and it's a huge order, really, but we have to even educate, my audience on the purpose of the research, how it's done, and why it can be trusted. What are some of those markers that we can, look for in a legitimate organization that's seeking to help me versus to exploit me. That right there is what we're, needing more of. within the Black community overall in order to establish that trust. And then next, knowing what next steps are. We kind of hang in the balance. You go to the doctor and, maybe they're ordered tests. And then that's kind of like, what's next? People are oftentimes left hanging. They'll get results to simply say, we found something or we didn't find something, right? And with COVID, unfortunately, oftentimes certain things are not found, and then they think that's just the end of the road. So in order to, establish that trust, we kind of need a map to see, if you have gone to point B, right, and point B is a dead end, will these providers show me what my next step is, help me with my next step, or do I have to come up with the magic question, in order to continue to get serviced and to continue to have my issues looked into? So not knowing what's next, I think, and not truly telling patients what their options are is one of the reasons why we do have a distrust. So more transparency, more patience in educating the patient is how we can establish much more trust.
There's a lot of wisdom that you're sharing right now, and I appreciate that. And there's something that you've said, the second part of what you were talking about, which the research community, and I don't speak for all of them, but in the social sciences, certainly we struggle with this too, particularly after disaster. We want to gather data, but we might want to gather data from communities that are distant from us, either geographically or, just who we are as people, and they're not in our community. How do we do that? It's not that we shouldn't do the research, but you're indicating there's an approach which we might call mutual aid, in which there has to be some reciprocity there. And I just wanted to highlight that part of what you said, because I know there's the researchers who listen to this program are interested also to do their work in a way that builds community rather than extracts information from people and puts it in a journal article. And you're nodding, so I'm hoping that's resonating with your experience.
Absolutely. It's absolutely resonating. Exactly. The way extracting information, that's really what's happening, and to a large degree, I would also say, really, I have to look at these surveys a lot because that's what I'm approached with most often. And a lot of times, the surveys, kind of the proof is in the pudding that they're just simply trying to extract the information, is that they're not constructed in a way that's considerate of who's on the other end. Okay. So for example, I'm a person who loves research, first of all, and I like data. So as a person who already has that type of interest, I myself have been exhausted by the length of a lot of the surveys, by the language of many of the surveys. Even some of the information that was asked that I really wasn't sure, like, well, why are they, asking this, and how does that kind of fit into the grand scheme of things, right? And so if you think about the average, person in the Black community who may not necessarily have an advanced, post-college education and understand, the little bit extra that I might know, it can be very intimidating, to participate. It can be very intimidating to talk across social economic status with those researchers, with those doctors, with all of the people with the letters behind their name. That could be a very intimidating process. And so in order to get the information that you're looking for, I really think there need to be more liaisons within the community who are working with organizations like, patient-led research, who are working with the CDC and the NIH, who are already embedded in the community. And those resources should be utilized and leveraged as much as possible versus, having new faces at the doorstep who are simply saying, give me, we want to know all about your experience. And also just in that process, having the empathy is necessary. Well, how do you express, empathy, when you're trying to look at people as subjects? Understanding that, they oftentimes need connection to resources, and they need to know about the resources that are available. There's sort of I guess a mistaken ideal that, we'll put all the resources up on the CDC website, and then all the people who need to know, about them will just, in droves go to the CDC website and start looking up, and finding local area resources, right? And that isn't considerate. It doesn't take into account, who it is that you're trying to drive and who you're trying to inform. So, really being able to reach people with the language that they understand, with people who are familiar to them, who understand the struggle that they've been through, who understand even the history of, you know, uh, the history of distrust and that is there with the healthcare system. Um, all of that, is a major factor in being able to gather the information that you need. So just taking a more sympathetic approach, as I said, and speaking on the level that allows people to say, okay, even though I'm giving them this information, they have shown me, that here are some other routes and places to go look into that
Right.
may be a help.
Just want to give people a quick reminder. You're listening to COVID Calls, and I'm talking to Terry Akintunwa and Lisa Mccorkle today about long COVID. Lisa, let me bring you back into the conversation here and ask you about the Patient-Led Research Collaborative, and maybe tell us what patient-led research is and what this organization advocates for. And we were chatting for a moment before we started here. You testified before Congress recently too. So you're getting attention paid to these issues. They're out there, but I'm curious to know what the organization is doing and what its main objectives are at this time.
Yeah, thank you for that question. So Patient-Led Research Collaborative is a group of people with long COVID. We all have a variety of backgrounds in some sort of research. My background is in policy and advocacy, and some data analysis. And we have neuroscientists, we have physicians, we have people who are experienced in machine learning, just a wide variety of skills and backgrounds. Most of us got sick at the beginning of all of this in March 2020. And we have, at this point, issued two big reports. So one was the first research that was done on long COVID. This was in May of 2020. The second one we published in July, which I can share that link to that. And this is, so all of our research is done by patients in collaboration with patients and for patients. And that really is what our whole thing is about, is patient-led research. We've seen just how valuable having patients at the table in any research can bring. And I mean, Terry really hit the nail on the head with this. I mean, I've seen and have taken so many surveys and been a part of research that I don't even know how to answer the question because it's not framed in a way that I understand or that mirrors my experience. And it's just so very clear that like no patient was involved in the development of that survey. And, often it's not culturally competent. It's not using language that would make sense to many people that are taking the survey. And throughout the last year and a half and being part of Patient-Led Research Collaborative, our main mission is, yes, to do research on our own that is, done by people with long COVID, but also to partner with bigger institutions and helping them make their research better. Because, we're pretty limited in the type of research that we can do. We don't have access to labs and we can't run blood tests and, we have a lot of limitations. But that being said, we can partner with those labs and make sure that people who are part of those research studies are getting their data back, just like Terry was mentioning, that people are getting that reciprocity, that it's not just a gimme, gimme, gimme situation. And that the research is going to actually make a difference, that it's asking the right questions. So often research is done, I think, often maybe it's an interesting hypothesis that a researcher has, but the answer to it may not have a very valuable impact on patients' lives. And so just making sure that researchers are asking the right questions that will get help to patients sooner, and that will give them valuable information by participating. And ideally, I mean, a big part of this is, often, I'm sure Terry has had this experience as well. We as patient-led research and many others have been asked to give feedback on surveys. And, the research community is kind of getting wind of the fact that their research is going to be better if they involve patients. But so often that work is unpaid. It's not compensated. It is seen as like, I'm not entirely sure why it's not compensated, because I think the value that we add is immense and really helps with the research. And especially with people who have an illness that the hallmark symptom is, don't exert yourself, don't push yourself too much. We need to make sure that, that is being understood by researchers, and that we are being compensated for our contributions.
Just follow up on that. I mean, you shared a link to an article characterizing long COVID in an international cohort, 7 months of symptoms and their impact. I mean, first of all, I'm just really, as you just said, I mean, the fact that this is patient-led research led by people, as you just pointed out, where the number one symptom of long COVID is exertion and stress related to exertion. That's really profound. It's in the Lancet. I mean, so this is finding its way into super established venues. Say a little bit more about that process. And I think you were just getting into that there in your final comment about compensation, about how seriously this work might be taken. What you're describing, we might be on the sort of a breakthrough moment for a new model of research, but I don't want to overstate it.
I mean, I hope you're not overstating it. That's that's largely what Patient-Led Research Collaborative is aiming for. We're working with PCORI and with Patient-Centered Outcomes Research Institute on hopefully developing a model where this type of research is more sustainable. Because at this point, we've been lucky enough to get a couple of very small grants just the last few months, but for well over a year of our work, we were completely unfunded and just working for free, and knowing that this information is valuable, and if we're not going to do it, then no one is going to. But it's, we're just getting to the point where we're being compensated and have enough power that we can demand that compensation. But we want to make sure that that type of model and that compensation is extended to beyond our group, other long COVID groups, but also other illnesses. And so that other patients can do their own research and build a similar model to ours.
Just recently, I had Yale epidemiologist Greg Gonsalves on as a guest on COVID calls. And, Greg has been a real outspoken critic of not only the Bush administration, but the Trump administration, but also Biden on the vaccine issue. But, Greg's background is one which I think is interesting for this conversation because, he comes out of the HIV/AIDS activist community. And I'm not sure they were calling it patient-led research in those days, but it's a quite similar model, that it's really the community of those who are impacted by the disease and those who surround them and can make solidarity with them, who are simultaneously having to learn what it is and express that scientifically, but also be activists. And that's a tall order. That's a lot to ask people to do when they're also managing disease. So I guess, I mean, that comes to a question, Lisa, I want to ask you first, and then Terry, I'll come to you. How do you build stamina in your organization? I mean, I'm concerned about that. How will you be able to sustain the work going forward? It's hard to prepare for testimony to Congress. It's difficult to prepare a research study that goes in the Lancet. How will you carry the work forward?
Yeah, and I want to briefly touch on that. I mean, ACT UP and TAG and all of the HIV/AIDS activists that came before us really opened a lot of doors for us and enabled us to, I think, be taken more seriously and have the opportunities of testifying to Congress. They laid a lot of the groundwork for that. So I appreciate you bringing that up. In terms of sustainability, we are just so at risk of burnout. And I don't entirely know how we're going to keep going. I think it's just, we know that there's so much work that's still left to be done. And we care so much about our community that we know we just have to keep on working. And I think that it's finally coming to a point where people are able to turn their attention from the acute COVID situation and realizing that there's this giant wave of disability that has been here for a year and a half now, but people maybe have, I think, the resources and the time to pay attention to it now, and maybe we're being loud enough. So I'm hopeful that that will lead to more funding and people being able to turn their full attention to this work. But I mean, it's tough. Many of us are not getting better. I guess I am lucky enough that I have gotten significantly better over the last couple months. But many people within Patient-Led Research Collaborative are still very sick and getting worse. And that's a tough spot to be in when you're trying to be an activist. It takes a lot of effort and a lot of energy, and you have to jump at these windows of opportunities. So I guess all that being said, if anyone has ideas for how to not burn out, we're open to them. We're just trying to keep going.
I'm glad you're feeling better, and thanks
you
for sharing that. And that's an important part of this, not to lose sight of, is how you're doing in all this, and how your family is doing. And so we just want to remind folks, you're listening to COVID Calls. I want to come back to you, Terry. There's another topic we want to talk about, which is kind of on the ground impact of long COVID for people's ability to work. And I wonder if you could speak to that a little bit, what you're hearing, what you know about how long COVID affects people's ability to work, the accommodations that they've been able to get. I think that's a particularly acute question right now, because in industry after industry, it seems that the desire is to bring people back to the physical workplace. And so the accommodation to work from home, and we've heard this from the disability rights community throughout the pandemic. You made accommodation for people within a weekend when it was necessary for people to work from home. Please don't discard that knowledge when it's possible for people to come back. And I think long COVID sufferers are right in the middle of that. So I wonder if you could talk a little bit about work in the context of long COVID. I think you're muted, Terry.
Sure. I've seen a lot of long haulers who are saying that they're not able to return to work. In fact, it's quite surprising, the number in my group alone who have expressed that their physical ailments have been so overwhelming that they're not able to continue on working, or they're not able to continue in the same line of work that they were doing prior to contracting COVID. As far as accommodations go, I've seen people who have said that they've requested to remain remote workers instead of returning to their, physical workplaces, which a lot of people did once the vaccinations became widely available. But outside of that, other accommodations, people are being met with resistance from their employers. And in lieu of being able to have those accommodations, people are voluntarily leaving their jobs, rather than, face termination because they're not able to, keep up with the tasks that are required for their role. In this particular aspect, I think that we could use more advocacy in showing patients alternatives, accommodations that could be made for them, that they could propose. And these are the things that they need to work along with their healthcare provider, to come up with and to be able to go in strongly, to their workplace and say, look, I want to still work. I can still work, but, we just need a few adjustments. Employers, I think they're afraid. They're afraid of liability. When they see, requests for accommodations, there's this kind of, we have to take this to our lawyers. It's not just, an HR matter, but this is, what type of implications will this have throughout the whole organization? And unfortunately, it does cause a lot of people not to be able to fulfill the duties. I've faced that myself. It's an ongoing situation where, I felt discrimination and retaliation as a result of having submitted my formal request for accommodations, despite it not costing the company any money, despite it not being an interruption to, how business is conducted. They still refuse to, to grant me, the accommodations. And a lot of other types of microaggressions, I guess, often are the result. I know I experienced it, and just in talking with my community members, I've also seen where, people are having to somehow prove and justify, what their ailments are, what their new disability is. And, having approached your job as an able-bodied person, and now to have a lot of invisible illness, that, you have to defend in a way, has really made returning to work or resuming work really disastrous. It's made it difficult mentally, to deal with that struggle of, not being believed or not having your value still, being seen as a valuable team member and contributor because of, this one little thing here on the side that, I simply need a little adjustment, but companies are taking those adjustments and those accommodations as major threats to how they conduct business and what their possible liability may be. So it's unfortunate, that we don't have, it would be great if all of our ailments were very visible and easily, to be seen, but, it's just not what the case is. So whether they're, mental health issues or whether it's cognitive, changes and or the physical, implications of exhaustion and so forth, we have to be able to be met, where we are, and to have an advocate in the workplace who will truly understand that, our desire here is not to have an I caught you moment or I got you moment, at work, but to truly get into society.
Lisa, just picking up on that, in terms of, can you characterize yet the sort of trends across the United States or other countries that you may know of in terms of Americans with Disabilities Act or similar types of laws, complaints, workers' compensation complaints? Is it yet scrutable what's happening across the country in terms of those those complaints? Because I could imagine that the numbers, and maybe this is what the employers are reacting to. I don't really know or want to characterize their position, but I can imagine. I mean, the numbers will be large.
Yeah, I haven't seen any data on the specific complaints and what that has looked like. I will say, I mean, this is just to kind of put in context what the issue is that within our respondents to our survey, 45% of people with long COVID required a reduced work schedule, so we're not able to work their full-time schedule they were before, and nearly 25% were unable to work at all. So this is, I mean, when we're looking at millions of people with long COVID and 65% are not able to work their full-time job, this is a huge issue. And accommodations will make a big difference. It made a big difference for me. I wouldn't have been able to go into work and continue working if I wasn't telecommuting. I think another one to add that hopefully if any employers are listening, that they'll consider for any of their employees is flex time is huge, especially for long COVID. So being able for people to be able to set their own hours. Often people can work a 40-hour week. It's just that they have insomnia, so they can't wake up for an 8 a.m. call. Or they need to take a lot of breaks throughout the day so that they don't get post-exertional malaise and their symptoms are triggered. But yeah, I mean, there definitely is a lot of issues with getting accommodations. There's a lot of issues if someone is not able to work, getting disability benefits. We're seeing so many people get rejected from getting disability benefits. And that has been a problem for decades and decades. And I think, it's just going to become more and more of a problem as the system is not fixed.
We're almost up on time in our COVID calls discussion today, but I wanted to just a couple other quick things I hope we can get to. One of them, I guess it will be almost impossible to quantify, but there must be, I want to ask you how your community sort of grapples with this. There must be people who are just really afraid to come forward about this, or who maybe they do initially and then they withdraw. And I can imagine, because of what you were just been talking about, both Lisa and you, Terry, with what long COVID sufferers face in the workplace, but also maybe disbelief and stigma when they go to the doctor, or in their own social network, in their own families. And so I guess I'm just wondering, how many you've both taken the brave step to be organizers and activists. You're out front, but I mean, how many thousands of people are suffering in silence right now, Terry?
Yeah, there really are a lot of people who they just don't know what their rights are. First of all, they don't know what their rights are in the workplace, and yes, they are fearing some sort of retaliation, whether it's from the employer or from peers and coworkers. And so reaching out and trying to ask for help has a lot of risk involved. A lot of times it can just be easier to give up, than to press forward. At least that's how it seems to a lot of people. And unfortunately, it's having a huge impact on, your economic stability. I do see quite a lot of people who are needing to leave their jobs or can't work, and they don't have a plan B. There's nothing in place for what they're going to do next and how they're going to pay, their rent, next month. But it's absolutely necessary for them to, to suspend working. So, yeah, there are a lot of people who are being affected, and they just don't know what to do next. So it's like, what I do know to do, I'm afraid to do. And not really understanding that there are other options. There are advocates out there. There are, ADA advocates. You can, speak with an attorney if need be, concerning your job. And everything doesn't have to, be, it doesn't have to be a scary thing to navigate. As long as you have advocates, as long as you have someone there who's willing to point you in the right direction, I think that we can really face anything, whether it's in the workplace or whether it is getting the treatment that we need from our doctors. We just have to know. And when we know better, we can do better. But we have to have people who are willing to inform us, who are willing to show us the way and help us understand, what the next steps could be. What are our options to take out the fear in the recovery process.
Well, that's a strong message to people who may be suffering and not yet ready to come forward or getting exhausted by it. And Lisa, and just as we're wrapping up, what's your message to lawmakers who have not yet taken this problem on board, but they may be representing thousands of people in their districts who need support, who need understanding, who need research? What are you saying to them?
Yeah, I think, right now we have in the United States, we have a bill in Congress where we can get increased access to an increased amount of paid family and medical leave. And our lawmakers at this point are not willing to push that forward. That is huge. Having the ability to rest at the beginning of your illness, having the ability to have someone take care of you while you're sick, can be huge for someone with long COVID. And I think, the disability benefit system has been broken for so long, and we just do not prioritize. I think this whole pandemic has made it very clear that we do not prioritize disabled people at all. And we have deeply internalized ableism that is something that also causes people to not come forward with their illness or be afraid to tell doctors or their loved ones. And quite frankly, we just need to get over that. We need to be able to provide for every last member of our community. And right now we are letting people fall through the cracks. And it is the people who are most vulnerable. And it's often the people who you don't see because they're not able to be out and about. And we really need to prioritize our disabled population and increase access to disability benefits. There's very easy solutions to a lot of these problems, and we just need to move forward with them.
Just a reminder, you've been listening to COVID Calls, and you can usually catch COVID Calls live at 6 p.m. Eastern Time. And I want to thank my guests, Lisa Mccorkle of the Patient-Led Research Collaborative and Teresa Tyndall-Akintunwa of the Black COVID-19 Survivors Support Group. I learned an enormous amount in this conversation today, and I also just want to say thank you for the advocacy you're doing, because you're advocating for long COVID sufferers, but also, as you just said, for people who have disabilities of all types. And I feel like you're advocating for me. I mean, I feel like this kind of advocacy is for everyone. And so I just want to give you a shout out for the work you're doing. Thanks so much. And thanks for joining me on COVID Calls today.
Thank you.
Thank you so much.
Stay healthy, everyone. We'll see you next time on COVID Calls.